Hi, I'm Stratty Regelis, and I'm here to talk about from Oakland, California. In the photograph, you see it's bright and sunny, and outside it's the same. I want to acknowledge my staff. As you can see, these are the people who are responsible for the photographs that will be shown and helping me deliver the care that we deliver. You see in the lower right-hand area my treatment arena where we have 4 treatment chairs, the logo, and our website for your use. Today we're going to talk about the keys to treatment efficiency and optimal outcomes using the 3 stages of active treatment mechanics to strategize wire sequencing and office intervals. Our new protocol using low pulsatile forces compared to the traditional protocol. We'll talk about case reports that move teeth at a rate faster than I normally would expected. We'll describe a non-extraction case, 2 extraction reports, a challenging a pre-surgical case, and 2 pre-prosthetic cases. All of us witnessing this webinar have taken patients, as you see with Sheila, and you've taken her in a period of time and got an acceptable result as far as the occlusion and a nice smile. Did this treatment take you 24 months, or could it be completed in 18 months? Imagine being able to complete this at a faster rate than normally expected, with a high quality outcome as you see here. And then of course stability 8 years later. How can we achieve this? All of us listening use a compass. We have treatment goals and treatment objectives. But now our clients have us on a stopwatch. They want to see how fast it can get done because we're in a generation where speed and quality are important. Imagine if you could do both. To do both, you have to understand the 3 keys to efficiency and optimal outcomes. Without saying, you have to have an accurate and complete diagnosis and measurable treatment goals. They have to be able to be articulated. You have to be able to quantify them. And then once you've quantified your diagnosis and treatment goals, then the mechanics becomes very organized. We all take a complete diagnosis on every case with mounted models, joint films, and photographs as you see. We have measurable treatment goals for the 7 characteristics that we want to quantify. Let's just take functional occlusion as an example. We all can ooh and ah when we see a finished result as you see on the screen. But in addition, we have to have a stable condylar position. We have to have adequate overbite for a mutually protected disclusion. And we have to have intercuspal fit so the case will be stable in a vertical dimension. We also have to have characteristics of an attractive smile. We're looking at gingival symmetry, gingival shape and contour, optimal dental proportion. We have to watch the buccal corridors and arch form, upper lip length relative to the teeth, and the smile arc. And the smile arc has 3 components. Incisal edges must match the curvature of the lower lip, upper lateral incisors slightly gingival to the upper centrals, and the inclination of the upper incisors should be proper for light reflection in addition to the functional aspect of creating a mutually protected occlusion. But we also have to position the teeth in the face. As you can see here on the images, we have 5 different photographs of 5 different people, but all with the same proportions and the same outline, lips together at rest, and as much chin projection as that patient allows. We have guidelines on how to position the teeth using subnasally vertical and positioning the upper lip, lower lip, and chin with some sort of proportions as you see there. This is all summarized in a chapter that I wrote in Goal-Directed Orthodontics, published as you see and can be available with the information at goaldirected.org. It summarizes the keys to treatment efficiency and excellence. With that as the background, what I have studied over time is 4 cohort studies over 20 years. I took 100 consecutive patients who I started in the January of the year noted. I had a control group, and then my sample cohort group was I made more accurate diagnosis with a mounted cast, clear treatment goals, and a more conscious effort for treatment efficiency. And then 5 years later, I did a similar cohort study with 100 consecutive patients. And then we measured this. And as I got into self-ligation brackets, we did another cohort study in the year 2004. The final analysis of this was that we increased practice efficiency by having more on-time finishes with each of the changes we made in the office. We reduced the number of office visits, and at that time we were using twin brackets. We also graded our scores. Most cases and studies that show speed of treatment rarely rate the scores and the cases. We rated them just as you would your grade point average in high school and college, with a 4 being an A and a 3 being a B. These are examples of how with each group and experience level we increase the improvement in the quality of finished cases. This was an example of a 4.0, this was a 3.5, and this was a 3.0. We used extreme score distribution to show that in general, over 50% of the cases graded 3.5 or above, 35% were 3-point or 3.5, and when you have a private practice like I do, you have some cases where you're doing dental compensations for underlying skeletal problems and, of course, missing a detail or two. Then in our fourth cohort studies, you see in the yellow on the right with self-ligation brackets, our non-extraction cases finished 2 months faster with 5 fewer office visits, and our extraction case similarly finished faster with 2 months faster treatment time and 3 fewer visits. So you can see my whole history over the last 20-25 years has been efficiency and grading efficiency. And you can see with each progression and each new device that we've added has improved our treatment efficiency. Now, of course, all of you read the literature, and you'll read in the one particular study that there is no statistical difference when you compare a self-ligation bracket system with a twin bracket. And if you look carefully at the study, while there's no statistical difference, you will see that the self-ligation brackets finished in 19 months, the mean finish, and the conventional brackets or the twin brackets in 21 months. Well, for those of you who are in private practice, 2 months is a big deal to the patient. Can you just imagine? And how many times have you seen the patient leave your office when you told them it's going to be 2 more months into treatment, as you see on the upper left-hand part of the screen? But on the right, a happy patient because they finished on time. So statistical significance alone doesn't convey the complete picture on the effectiveness of an intervention. And when you're looking at the difference between two groups, 38 years ago, pulsatile forces made their first entry into the orthodontic scene. However, at that time, nobody cared about rate of treatment. Now, with the presence of Excelident and the Aura 38 years later as the first introduction of low pulsatile forces, we now have the ability to increase the rate of tooth movement. It's in the medical community right now in the form of physical therapy. If you have a deep sore or a bruise, ultrasound is used to stimulate blood flow to get the weekend athlete or even the high-powered athlete back on the floor sooner than expected. There are a number of accelerated tooth movement technologies. I have chosen mechanical pulsation in addition to the Forestident hybrid self-ligation bracket system to enhance the rate of tooth movement in my patients. It does it on 2 levels, increases osteoblastic activity and reduces the hyalinization formation to allow for more quick tooth movement during the early stages of treatment. This is a histological slide to show that under low pulsatile forces, there's engorgement of the blood supplies in the craniofacial sutures. The scientific publication review is exhaustive. High-frequency acceleration induces expression in bone markers. This, in the AJO, the molecular mechanism was discussed. In another AJO article, stimulation of osteoclastic formation and bone remodeling was discussed also. Vibratory stimulation increases interleukin-1 beta secretion to increase the rate of tooth movement, as well as electromagnetic field vibration information. So the scientific literature is there, and it's well documented in the refereed literature. What I'm now going to do is show you the 3 stages of active treatment and the mechanics used that we are using. 3 stages. Stage 1 is align, level, and begin arch coordination. Stage 2 is the working stage. This is where we're doing AP movements, transverse movements, vertical movements. And stage 3 is the classic finishing stage, or detailing. In a non-excelodent patient, there's stage 1, stage 2, and stage 3. With the excelodent patient, we are moving the needle, so to speak, to the left, shortening up stage 1, shortening up stage 2, and giving us all the time we need to do the high-quality result in stage 3. So where's the evidence about tooth movement? Early evidence came from Mondal. In his study, 6 to 9 months was the amount of time it took him to level, and he defined leveling reaching the stage of a 19 by 25 stainless steel working wire using an 022 appliance. So on the average of 6.8 to 9.3 months. Jay Bowman, in his study in the Journal of Clinical Orthodontics, said his study showed 5 months with accelerated tooth movement and 7 months without the accelerated tooth movement. Stage 2 evidence, the rated tooth movement during space closure, closing the anterior teeth against a TAD, was about 38% faster compared to the non-excelodent side. My clinical experience is that in this patient that you see, it took me 13 months to close that space using one-way mechanics with an anchor system to hold the molars in place, and then it took us another 5 months to finish it. So stage 2 took 13 months of full space closure. Stage 3, 5 months. In combination, it took 18 months. Stage 3 evidence varies. These are images from other websites on accelerated tooth movement. You be the judge if this is the finish that you want to have in your cases. This is in the focus that the orthodontist wants to have as far as functional occlusion and smile aesthetics. So as we go through the cases, you are really the control group. You are going to look at these cases and say, how fast could I do that? Could I do it faster, or is it about the same? What would your treatment times be? So let's go through a couple case reports. The very first case I treated was Heidi. Heidi was a class 1 adult non-extraction. She had a crossbite at the lateral incisor area, edge-to-edge bite, with a previously extracted upper left bicuspid. Begin to imagine what you would do, and begin to imagine how long it would take you. We do a complete diagnosis. We notice that about 10% of the incisal edges are worn due to the edge-to-edge bite. We have a seated condylar position and maximum intercuspation relatively within the range of normal. We do a diagnostic setup, as I often do in patients with missing teeth, to ascertain the amount of space needed for prosthetics when we're completed. So I began our treatment. Stage 1. So begin to imagine how long it's going to take you to open up that space and get the overjet and overbite that you would like. We're using a hybrid appliance, active cuspid to cuspid and passive in the posterior segments. Stage 1, leveling. 7 months later, we are completed with the lower arch alignment and beginning to do working stage of opening space and developing AP improvement. Occlusal views of those same images. Day 1 on the left, 7 months later on the right. Look at tooth positions, tooth angulations, and the amount of space that's being opened up. 10 months into treatment, I'm beginning the finishing stage, or stage 3. I'm using a flexible wire with step-down bends to give us the overbite and cuspid intercuspation that we need. We do our due diligence on the extraction site, looking at CBCTs to look at bone morphology and what kind of restoration is going to be placed in the edentulous area. Notice that there's no radiographic evidence of root resorption at the time these images were taken at the completion of near completion of treatment. 12 months, 2 weeks later, 100% compliance. Would you expect that result with the traditional protocols that you would normally do? For me, this was an improvement because I estimated 16 to 18 months of treatment. Little or no discomfort during treatment is another interesting finding we saw early on. As I said earlier, no radiographic evidence of root resorption, which is one of the common questions asked. Did we meet our treatment goals? We maintained the facial balance, and in fact, if you look closely, we have a little more upper lip curl because of the advancement of the upper anteriors. We went from a reverse smile to a straight smile, keeping in mind that she had already lost 10% of the incisal edges of her upper incisors. If we were to visualize adding composite material to the centrals, she would have a smile arc that mimics the lower lip. Stability. Here she is 18 months later. Arches are holding. At this time, she's using a little clip-on prosthetic until she decides what kind of restoration to place. Here she is 3 years later. Stability is still there in the upper arch as well as the overbite. So on my non-extraction cases, if you looked at the previous studies that I had been showing you, twin brackets, cohort studies 1 and 2, at stages 1, 2, and 3 that you see. Then we switched to the SLB or the self-ligation brackets, and we even got stage 1 even shorter, stage 2 a little shorter, and stage 3 about the same. And with accelerated tooth movement, specifically low pulsatile forces, stage 1 became even shorter, stage 2 became shorter, and we're finishing about 33% faster with Excelodent. Now keep in mind, these are fixed appliances I'm focusing on, and of course low pulsatile forces are very effective in clear aligner cases, but the focus of this discussion is on fixed appliances. Our wire sequence. We start out with a 14 or 18 NiTi wire, go to a 20 square NiTi, reset brackets as needed, and then get to the 19 by 25 NiTi. Our stage 2, we stay in a stainless steel wire, 19 by 25 stainless steel. And then at stage 3, we reset brackets for the second time, progress through the 19 by 25 NiTi wire to a stainless steel wire, and finish with multi-stranded wires. Stage 1 variabilities are the amount of crowding. My goal is to get to a stainless steel wire in less than 4 months. 14 or 18 NiTi, 4-week interval changes. So we schedule these patients with 3 4-week intervals and eventually getting to the stainless steel wire in less than 4 months. Take advantage of stage 1's ability to move teeth very, very quickly. Do not let the patient go out 6 or 7 weeks. This is why statistical studies show that there's not much of a difference because they're using old protocols. Keep in mind we're using advanced protocols to take advantage of stage 1 movement and mobility. Stage 2, the working stage, the variabilities of the overbite, overjet, transverse positions, vertical controls, and of course patient cooperation. Here we use NiTi springs exclusively on a 19 by 25 stainless steel wire, knowing very well that we can see the patient every 6 to 7 weeks. So the office intervals get spread out. Take advantage of stage 2 and NiTi springs with regard to space closure. Next 3, my goals are the mutually protected occlusion, a balanced profile with smile aesthetics, and I want to have it take no longer than 4 months. I have to have a class 1 molar to begin, I have to have overjet and overbite within 2 millimeters of optimal, and no intra-arch spaces or lateral open bites greater than 2 millimeters. We reset brackets, put the biggest nickel titanium wire we can that can close the clips, and we progressed to the 19 by 25 stainless steel wires, and as I said earlier, finished with multi-stranded wires, which you'll see in the next few cases. Let's take Luciana. Luciana is crowded. In my hands, I diagnosed this with crowding, thin gingival tissue, a facial pattern that I do a VTO on, and I can see that if I carefully control my extraction sites, extraction of 4 bicuspids, and PM extraoral traction to hold my class 2 is the treatment of choice for me. Nickel titanium wires, day 1. Notice the crowding. 2.5 weeks later, she comes in the office for a pokey wire. No tooth pain. Notice the alignment. We upgraded the wires. 7 weeks into treatment, less than 2 months, we're in the 19 by 25 NiTis. Notice also how the lateral opened up. Very parallel occlusal planes. Overviews of the occlusal views from day 1, 2.5 weeks later, and 7 weeks later. Notice the alignment. We're now beginning stage 2. Now keep in mind these are my early cases, so I'm using a double keyhole loop. I've learned now we do not use the double keyhole loop. We're using NiTi springs, so we don't have to see the patient as often, as the patient's teeth will move at a faster rate. 5 months into treatment, some class 2 elastics on the right side. We are now 14 months into overall treatment. Space is closed. We started stage 1 on the left, finishing stage 2 on the right, 10.5 months. Now we're ready at 15 months for stage 3. We reset brackets. We put the biggest nickel titanium wire in we can, use some triangular elastics nighttime as needed, section the wires as needed as you see to get the vertical overbite we need, and treatment time almost 18 months. Compliance with the Excelodent was 95%. We had parental limitations. I could only see the patient on Mondays between 1:30 and 4, so I had one hand tied behind my back, but we were still able to finish this extraction case in almost 18 months, and you can see the breakdown of the stages. Intraoral photographs, lingual occlusion, no radiographic evidence of root resorption. Notice the incisor control. This is using an active anterior bracket and a passive posterior bracket and the self-ligation bracket system. We had control of the anterior teeth. Our superimposition showed that yes, we extracted, but we didn't retract. We held the vertical with the nighttime high pull headgear, the self-ligation brackets, and Excelodent. All those factors kept upper molars up and lower molars from extruding very minimally. We got maximum chin projection and a relaxed soft profile. That was our VTO, our actual treatment. So we had extractions, yet we have a balanced profile. We had extractions, but we have a broad smile. The myths of extractions and flat faces, the myths of extractions and narrow arch is in operator control. The operator dictates the arch form with the shape of the stainless steel wire. 18 months later, wearing retainers only at night shows stability. So my extraction cases with Excelodent are finishing 4 months faster than my cohort study 4, in which a 2004 sample showed that we were finishing them in 22 months, and now we're finishing them in about 18 months. In summary, the studies have shown the following. Just as we did with non-extraction, my extraction cases are finishing about 25% faster. Reviewing the wire sequence one more time, we start out with the biggest nickel titanium wire possible, getting to that 19 by 25 NiTi, getting to the working stage using posted hooks with NiTi springs, and resetting brackets, biggest nickel titanium wire possible, and then into the stainless steel wire as needed. Keep in mind, because the patient's teeth are not uncomfortable, they don't hurt, you can push the wire in and use the coolant. We're starting to lose sight of the fact that these nickel titanium wires are thermally activated, and you can use a coolant like a Freon to cool the wire, make it spaghetti soft, insert it with a probe, close the door so that you can advance the wire sequence comfortably for the patient. Let's take Emma. Class 1, myofascial protrusion. She had an impacted cuspid. She was 14 years of age, and she was interested in speed of treatment. But in addition to that, we looked at her bite. The seated condylar position and maximum intercuspation showed a vertical discrepancy. You look at her facial pattern, short posterior face height, counterclockwise rotation growth potential. We wanted to maximize her profile. So I did an extraction sequence of VTO, a visualized treatment objective, and showed that with reciprocal mechanics, I could hopefully retract the upper teeth slightly. The lips will be more relaxed, giving her more soft tissue chin projection. That was the diagnosis. Those were the treatment goals. And now efficient mechanics. Stage 1, level and aligning. 4 weeks later, 8 weeks later, we took out the impacted upper cuspid and took out 3 remaining bicuspids and other quadrants. In 2 months, we were in NiTi wires. And we finished stage 1 at 3 months as we were banding second molars. Notice the level occlusal planes. We made a rapid onset into getting into stage 2. Now, again, typically I would have NiTi springs so I could see the patient every 6 to 7 weeks. We're closing spaces, and as we're closing spaces, note the parallel occlusal planes of the maxillary arch and the mandibular arch as we're closing those spaces. 6 months in stage 2, 4 office visits. 88% compliance with Excelodent. Ready for stage 3 at 11 months. We reset brackets, largest nickel titanium wire in possible, use some triangular elastics as needed, and in 15 months we have this outcome. Extraction case, 15 months. Reciprocal mechanics. Our finished occlusion shows seated condylar position and max intercuspation relatively close. Lingual occlusion for stability. No radiographic evidence of root resorption. You would never know the canine was removed. The VTO shows a balanced facial profile. Keep in mind, extractions does not equate with retraction, does not flatten the face. We have curl. We have proportions between the upper lip, lower lip, and the chin with a relaxed chin contour. So Heidi took 12 months with traditional wire sequencing. Case report 2, Luciana, took 18 months with a new protocol. And case 3 report, crowding extractions, 15 months. Accelerated tooth movement with low pulsatile forces works effectively. It moves the entire needle to the left. But you have to have an accurate diagnosis, you have to have clear goals, and then be very efficient about treatment. You can't go from stage 1 to 2 and then back to 1 again. You have to be regimented about your treatment sequencing. Clinical publication review is becoming exhaustive. There are countless articles with case reports and studies showing the clinical efficiency of low pulsatile forces. However, what we often see is case reports where they're trying to use accelerated products to resolve mechanical problems, trying to do difficult tooth movements. And I like to call them the Ripley believe it or not cases, trying to do something that's only works 1 out of 1,000 times or 1 out of 100 times. Patients and parents ask us to do the impossible or highly improbable, and we get caught up in that scenario. We have to be very careful that most of our mechanical challenges are a result of an incomplete diagnosis or unclear treatment goals. And then if you keep that in mind, we can do smooth, efficient treatment if our goals are clear and our mechanics are smooth. I chose low pulsatile forces because my goal was to move patients with tempo and pace in a non-invasive accelerated tooth movement technology. Let's segue into 3 other types of cases that I treat with very positive changes. How about the pre-surgical case? A patient gets accepted for jaw surgery, they're excited, they ask, well, we have to wait 12 months to have the teeth prepared. Wouldn't it be nice to have a technique to accelerate the rate of tooth movement so that you can get the patients into surgery faster and they're happier? Still cannot get around doing joint films, analyzing the muscles. She had myofascial pain. This was her pre-treatment cephalometric image. We do a surgical VTO to show the feasibility from a facial standpoint. We do our mock-ups to show how much tooth movement we need to achieve prior to surgery. She wore a orthodontic splint for 2 months to alleviate her myofascial pain before we started treatment, giving her confidence that the bite, when it's improved, will alleviate the pain, gave us the assurance that the myofascial pain was related to the teeth. We now progressed. We took out 2 upper second bicuspids to alleviate the crowding, and let's watch and see how fast this space closure takes. Stage 1, leveling and aligning. Now the lower arch will be very easy. 100% compliance. 1 month later, the teeth are straight on the upper and almost straight on the lower. 1 month. At 3.75 months, less than 4 months, we're in closing mechanics, just as we want. We want to get to that stainless steel wire in less than 4 months. And now we're ready for surgery. We're ready for surgery, and we're waiting for the surgeon to do the work. We got ready for surgery in 9 months. Closing the space, improving the inclinations and angulations. Here she is 3 months post-surgery. So we have now 1 month prior to surgery, 3 months post-surgery where we're just letting the pieces settle and heal. Here's our first arch wire, stage 2, doing a little space closure as it opened up at post-surgery. And we're finished. A few months in stage 3 and the case was complete. Mounted casts, arch form, CPI readings, lingual occlusion, a summary of 18 months with upper bicuspid extraction. 4 months of those months we were just waiting, 1 for pre-surgery and 3 for post-surgery stabilization. Here's the before, there's the after, there's the before, the after smile, and on the lower right, the final occlusion. So we met our treatment goals based upon an accurate diagnosis. While there's no radiographic evidence of root resorption, there's sure a lot of metal in her mouth, but spared the roots. And our pre-surgery and post-surgery was very close to what our VTOs were, so again, accurate diagnosis and treatment planning. The next case we're using in our office is the anterior open bite case. I don't know how it is for you, but in our office, these are challenges. We put up and down rubber bands. We hope that the tongue stays out of the way. We do our complete diagnosis, a significant difference in the seated condylar position and the maximum intercuspation. While she has a very attractive facial balance, her skeletal pattern shows vertical growth tendencies, short posterior face height, long lower mandible corpus length. I didn't give her Exceldent when we started. 1 month into treatment, the mom inquired about it because she heard that we offer this. So this is treatment just leveling and aligning with no Exceldent. I want you to look at the leveling, of course, but I want you to look at the generalized open bite. We talked about Exceldent. We gave her the Exceldent, used some nighttime elastics only. 1 month later, we're starting to develop our overbite. Now, I would have started this case a little later because her second bicuspid is now finally coming in, but there was an anxiety to begin treatment because of the high cuspids. Again, a private practice decision. Triangular elastics, resetting brackets. 4 months into stage 1, primarily due to the delay in the lower left second bicuspid. We're now into stage 2 and stage 3 12 months later. Very few vertical elastics are being used. 17 months of total treatment time, 16 months of Excelodent with only 60% usage, and we still got this result. My personal opinion, this was my first anterior open bite case I've treated, and we now are in the process of treating dozens like this. While treatment time may not have been spectacular, pulsatile forces, in my opinion, allowed her to attain this outcome. Here's her mounted cast, lingual occlusion. No radiographic evidence of root resorption once again. Our cephalometric images, vertical control, upper molars kept in space, lower molars kept in space as the incisors came together. How does this happen? I have a theory, and my theory is that the vibratory forces hold the molars from their vertical movements, just as you see here. And then the arch wire, when it's placed, straightens out and flexes to give us the straight outcome. As I mentioned a few minutes ago, we are doing this exclusive in our anterior open bites, and now in some cases we're seeing posterior bite tabs. Of course, skeletal anchorage is also used, but when it's within this amount of open bite, we're seeing very spectacular results in closing bites. Again, the strategies for space closure are stage 1, the amount of crowding, but our goal is to get to a 19 by 25 stainless steel wire in less than 4 months. We use the NiTi springs for space closure, intervals of every 6 to 7 weeks. And of course, the criteria and action items for finishing stage 3 are stated once again. Again, we want to move to the left. Have the cases go faster in stage 1 and 2 and hopefully 3. So summary case report 4 on Erica, 18 months. The anterior open bite case, 17 months with a history of growth. And now my final 2 presentations are another aspect that we're doing this using is on interdisciplinary cases. How many times do you get a patient that comes in for interdisciplinary work and they're in their mature stages? They want to get the cases done. There's extensive wear facetting, envelope of motion encroachment, deep overbites, and restorative material needs to be placed. They want to get going. So this is a perfect place for accelerated tooth movement because of the active movement in stage 1 and 2. We do our thorough diagnosis with diagnostic casts showing the dentist and the patient what we want to accomplish with tooth movements. We show in pencil the amount of wearing down of the teeth and show them what we want to accomplish. We do a diagnostic setup and collaborate with the dentist so that there's a team effort that's working. We want to intrude the incisors, improve the tooth gingival margins as we talked about in smile aesthetics, and we want to make space to improve proportions and length. So here's in 3 months, we go from irregular tooth gum margins to balanced gum margins using accelerated tooth movement, low pulsatile forces, Excelodent. 10 months later, I'm done. Now, many of you may be able to finish in this length of time, but for me, this usually takes about 12 months to 14 months to get to this stage. The interesting comment I got from the restorative dentist when I had the patient go back after 8 months to see if the case was going well and what other little tooth movements I had to do, her comment was, "That sure went fast." I didn't tell her about Excelodent until after we were completed, but the dentist was pleased that the case was ready for her use and restorative work sooner than anticipated. We met all the criteria for smile aesthetics and functional improvement. You can see the clearance on the lingual of the upper anteriors, and now the restorative work. It only took 10 months to get ready for restorative work, opening the bite, getting the tooth proportions, and then following up with the restorative work. Genetics and optimal envelope of function. And Kirsten is the last one I'm going to show. Previously extracted in her teenage years, retroclined incisors, deep overbite, very flat face, worn down incisors. The same protocol. The dentist wanted the cemento-enamel junction distance at the incisors to be at about 15.5 to 16 millimeters. I estimated 12 months of treatment. 10 months later, after doing our due diligence and making our changes, giving her clearance, we get the okay from the dentist. The dentist does the restorative work, and you can see the finished result. The pre-treatment, the diagnostic setup, and the post-orthodontic work, and of course, the icing on the cake are the veneers. Orthodontics provided a broader smile, improved tooth inclinations. The dentist improved tooth proportionality, created the smile arc, and we have some slight, but not much, upper lip curl. Original treatment times for these two patients was 12 to 14 months. All took less than 10 months. And with a few months later, restorative work was completed. And the comments in the adults with these worn down teeth previously in the new restorations, my jaw muscles feel more relaxed. All of you who are listening clearly understand this. When you do good orthodontics with great restorative work, when you're done, the facial muscles are relaxed. Why is that? Let's take a look at a deconstructed face. When the bite is even, the chewing muscles are relaxed. When the masseter muscles start to fire because of a bad bite, and you see the firings on this EMG screen, that pulls on the risorius muscle, which in turn pulls on the orbicularis oris, and you get these strained lips. So we as orthodontists have an incredible opportunity to improve bites, aligning teeth, teaming up with our restorative dentist to provide great bites, natural and aesthetic outcomes. And you see that with our pre-prosthetics, relaxed muscles with better bites. We haven't talked much about reduction in pain threshold, but that is clearly documented as an advantage with low pulsatile forces. The teeth, quite frankly, don't hurt as much as they would if you didn't use them. Probably analogous to if you got bumped with a soccer ball or a baseball and you rubbed it out with either ultrasound or stiff massaging, and that you allow engorgement of the blood supply to allow the toxins to flow out. This allows for more rapid tooth movement. This allows for changing your wires more frequently and allows for shorter treatment time. So how do we use Excelodent in our office? I like to think of our office as providing innovative technology while maintaining evidence-based principles. The science for low pulsatile force has been here for 40 years. Its technology is evidence-based. I like it because it's compliant-based. I want to share the responsibility of my care. It's like asking the dental hygienist to come to my house to floss and brush my teeth. No, we have to share the responsibility. And this is what I like about low forces. It's non-invasive with no disruption to the normal flow of your office. It works by keeping the tempo and the treatment at an accelerated rate. How do we present it? At the examination, after I discuss the findings and possible treatment solutions, I ask the patients, are you interested in accelerating the rate of tooth movement? Well, we offer an approach that will help you shorten the amount of time you're going to be in braces. Now, of course, we have message boards and low-key subliminal messages on our screens that point this out, and they will often say, after I hold the mouthpiece, put the pulsation on, have them feel it, they'll say, yes, I am interested. And when they're interested, the treatment coordinator takes over. She used it for her treatment, and she'll answer additional questions. What I like to think of is growing your practice with accelerated orthodontics. In addition to growing your practice with accelerated orthodontics, you're now becoming on the leading edge of technology that is science-based. Again, our philosophy is innovative technology while maintaining evidence-based principles of dentistry. Here are the befores and afters of the patients we showed today from an occlusal standpoint. The functional occlusion should be the same for all those cases, even though the original malocclusions were different, so the outcomes should be similar. The facial aesthetics and profile should also be similar. Similar treatment goals based upon an accurate diagnosis. I want to thank you very much for your attention, and what I would like to do now is respond to some of the questions, and I will start with lost sound. We got through. Volume back on. Thank you. Can't. One question was, why was the impacted canine removed as opposed to bringing it into place? She was 14 years old, and I gave them the choice of extracting the bicuspid in that area and bringing the canine down. I showed her a number of cases in which canines have been extracted that were much more, which were irretrievable, and showed them that the bicuspid, when properly fit together, will give us the same look, and if properly positioned, will give us the same function. So it was a choice I gave them. I told them the treatment time difference, and that's how they made that decision. Again, do you deliver the vibratory impulse? Do you deliver the vibratory impulses? How do you deliver? Its patient is delivering that vibratory influence with the pulses with their with the use of the Excelodent. Another good question is, how soon after surgery do you restart Excelodent, and does your surgeon like it or not? I'll answer the second question first. The surgeon loves it. Absolutely loves it, and the reason they do is the patient gets to surgery faster. There's a much more enthusiastic patient because they haven't had a lag phase. Our surgeon who we routinely work with, Dr. Michael Gunson in Santa Barbara, is most impressed with that and has actually talked to his other orthodontist about using it. Now, how soon afterwards? Keep in mind there's several methods of accelerated tooth movement, and one is a corticotomy. And quite honestly, when you go through maxillofacial surgery, you have a lot of corticotomies. So I'm not too concerned about using Excelodent post-surgery. So my major push is right up until surgery with Excelodent. And how do you choose the size of Excelodent, flat or open? We take the original arch form and customize the plastic wafer and size it to the appropriate patient. If it's a smaller patient or not as much AP distance, we can cut that off. Now, whether it's flat or open, studies have shown that you can actually not have vibratory force touching each individual tooth. It actually has a ripple effect of 2 or 3 teeth difference from where the contact point is. But keep in mind, as the teeth start to straighten out, the occlusal plane's leveled out, so more and more teeth come into contact. Follow-up question, I did not hear the answer on the surgery case question. The surgeon loves it. Dr. Michael Gunson in Santa Barbara is enthusiastic about it because he sees patients coming in a little happier because they don't have to wait so long to get prepared for surgery. And he, in fact, has talked to other surgeons, other orthodontists about that also. The last question is, do you have any video or link to YouTube or any of the websites where we and the patient can see how you use Excelodent? No, we don't, but I'll be talking with the Excelodent people, and perhaps we can put together a YouTube and they will be able to disseminate that information for you. I want to, no other questions that I can see. Oh, can you show us a picture of the pulsar? The answer to that question is the pulsation device is, pardon me while I backtrack here, it should be in one of these, right there, lower right hand. And now they're coming out with a new one called Excelodent now that doesn't have this right angle bend to it. And that's an example of the pulsation device. It's actually very discreet, and the new one that's going to be coming out in the next few months is really awesome. Very, very sleek. Almost looks like you're holding something 2 inches outside of your mouth. Thank you for the last question. He said, nice presentation. I appreciate that. Any other questions? Feel free to pass them on. It was a pleasure to speak with you. Thank you, and I am signing off at this time unless there's any other questions.